Okay. So Vanessa, let me introduce our first we're going to introduce the moderator, Jihun first. And
Thank you.
today's webinar is about the uh, radiobiology principle guidance precision radiation therapy. And our moderator is from the South Korea, Jihun Kim. First, let me introduce Jihun Kim, and he is a chief medical physicist and assistant professor in the Department of Radiation Oncology at Gangnam Severance Hospital, Yonsei University College of Medicine, Seoul, South Korea. He obtained his PhD in mechanical engineering from the University of Michigan and completed advanced medical physics training through the Harvard Medical School residency program. And his research interests including adaptive therapy, deformation image registration, MR-guided radiotherapy, image guidance radiotherapy, motion management, brachytherapy, and artificial intelligent application radiotherapy. And he has authorized more than 40 peer-reviewed publications and has extensive experience in training, treatment planning, quality assurance, and advanced radiotherapy techniques. He serves as a review of several leading journals, including Medical Physics, Physics in Medicine, and Biology, Physical Medical, and JACMP. I will pass to the Jihun Kim and warmly welcome Jihun Kim to introduce our speaker today.
Okay, thank you for introducing me, and thank you for having me as a moderator to moderate this session. And I'm going to introduce Professor Vanessa Panettieri. I hope that I pronounce her name correctly.
That was perfect, actually. Thank you.
Okay, thank you. She's an associate professor and she's a senior medical physicist at Peter MacCallum Cancer Center, Melbourne, Australia, which is a nice country. And she's also adjunct associate professor at Monash University and the University of Melbourne. And she obtained her PhD in nuclear engineering with specialization in medical radiation technologies from the Technical University of Catalonia in Spain, with research conducted in collaboration with Karolinska University Hospital, Sweden. Prior to joining Peter MacCallum Cancer Center, she worked at Karolinska University Hospital in Sweden, Clatterbridge Cancer Center in United Kingdom, and Alfred Health Radiation Oncology Australia, many countries in Europe. And her research focuses on predictive modeling, artificial intelligence in radiotherapy, automated treatment planning, stereotactic radiotherapy, radiomix, and quality assurance, and treatment individualization, covering many different research topics in medical physics. And she has more than 20 years of experience in radiation oncology and has contributed over 50 peer-reviewed scientific publications. So I expect that today's seminar will be great and insightful. And now the floor is yours, and please go ahead.
Thank you very much, Dr. Kim, for the kind introduction. I will share my slides now, making sure that everyone can see them before I start. Can you say something? Because I can't see you anymore.
Yes, we can.
Yes, thank you. Wonderful.
I can see your slides, and I think you can go ahead and you can just have the lecture without any intervention. Maybe just we can have a Q&A session.
We can have question at the end. Yes, fantastic. Thank you very much. And I just wanted to say good morning, good afternoon, and good evening, everyone, because I don't know in which part of the world you're at. As Dr. Kim kindly introduced me, I'm Vanessa Panettieri. I'm a senior medical physicist. I'm based here in Australia at the Peter MacCallum Cancer Center, and I am very delighted to be able to give you this webinar on radiobiology principle guiding precision radiotherapy. This is a topic that I'm really passionate about, so I hope I can bring some of that passion to you. These are my disclosures, but I think it's more important that we go back to the focus of this talk. So our focus is radiotherapy. And we know that radiotherapy is the most complex treatment modality provided in a hospital. We're not I'm not saying it because I am obviously biased a little bit. I work in radiotherapy every day. In fact, I arrived a little bit late because I was running from the machine, but it's written very nicely in this paper from the Lancet Oncology in 2013. So what I've been doing the past few years, and our focus has been on sort of optimize the delivery of the radiation. This is a graph that is shown very, very often in presentations around the world, but I think it summarized very well all the invention and all the technologically advances that we have been doing in the past few years. So what we've been doing is that we have continuously improved the beam delivery and the dose conformity. We have introduced all this very fancy technology. In turn, we have improved the anatomic conformity. However, as you can see here, we are reaching a plateau a little bit. So what we've been doing is that we have been focusing a lot on the technology. So spent quite a lot of time developing new machines, developing new image guidance system, developing, new ways of delivering beam, new ways of treating the patient. And in turns, as medical physicists in particular, we spent a lot of time in improving quality assurance and making sure that all these fancy delivery can actually deliver what we want to the patient in a safe way. Additionally, some of us spend quite a lot of time looking at what I like to call toxicity approaches. So looking at ways to reduce the side effects to the patient and to the normal tissue. So in a way, if we look at the therapeutic ratio, and I always like to thank one of our mentors, Professor Anna Hu, for providing this nice graph. And the therapeutic ratio, as you know, is the ratio between the tumor control probability and the normal tissue complication probability. What we have been doing is that we've been spending quite a lot of time improving this part of the therapeutic ratio. So try to minimize the side effects in order for us to be able to improve the delivery of those and maximize it so that we can have the maximum outcome for our patients in terms of tumor control. But have we really succeeded? Have we improved treatment if we look at the survival of the patient or if we look at the outcomes? So in a way, if we look at the way we've been adapting our treatment, we've mainly spent a lot of time doing geometric adaptation. So as you know, we do spend a lot of time prior to the treatment coming, designing the plan. We scan them in a certain way with a certain immobilization that then we can reproduce as best as possible on the machine. If the patients are not quite aligned on the machine, we use image guidance to correct them. So geometrical adaptation as such has been our main focus for the past years. If we look at the outcomes, we can see that in some cases that has been a game changer. This is very nice results. They're quite old, from 2012, but that was when IGRT became a little bit more mainstream in our clinics. And we have a nice work from the Sloan Kettering, in which they looked at prostate cancer and they looked at the difference in late GU grade 2+ toxicity-free survival for patients that were treated with IGRT and patients that were treated without IGRT. You can see that the difference is striking, is significant, and obviously this is not the only treatment site in which we have improved. We know that, for example, the introduction of IMRT with IGRT has improved vastly, some of the outcomes for head and neck patients. However, there is, of course, this is not so for all the tumors. We see some results from non-small cell lung cancer. So even in non-small cell lung cancer, we have definitely improved our technology. We've gone from treating the patients with a 3D sort of approach, so with a static scan, to a 4D sort of approach in which we have a 4D CT, in which we can also take into account the motion of the breathing of that patient in particular. We have introduced stereotactic treatments. This is something I'm really passionate about because it's where I used to work at the Karolinska. They introduced SBRT for lungs and liver in the early 90s. So that was a big revolution, and now it's becoming, standard of care for a lot of our patients. However, unfortunately, if we look at the results and the outcomes for these patients in terms of median survival, what we can see is that these sort of results have not dramatically changed in the way they have changed for some other tumor types. So what are we missing here? And this is what I'm aiming at with my talk. Look at all these tools that we have and all these focuses that we could be exploring further. So for me, the problem is that most of our research questions are not related to tumor control, but we spend a lot of time minimizing those to the organs at risk, and so the risk of side effects. Additionally, if we look at the way we do this adaptation and we look at, designing our treatment, this adaptation and this optimization of the plan is heavily reliant on the inverse planning technique nowadays. Most of us would treat the majority of our patients with VMAT or IMRT type or a sort of a modulated type of approach. And these are based on physical criteria, so dose volume histograms, in which often the optimization is based on a single DVH constraint. Sometimes you use some line objectives. However, often you use these sort of single constraints, which might produce a DVH which is pivoted around that constraint. But as you can understand very well, not all of the DVHs that meet that constraint might lead to the same biological outcome. And here we go to the other major problem. The major problem is the tumor itself. So the major cause of clinically observed radioresistance lies in that biological heterogeneity of the tumor tissue, which brings us to the different radiosensitivity of different tumors, not only, let's say, among patients groups, but also between the patients themselves, like among the patients in the same tumor groups. So we have a tumor which has a chaotic nature in the way they grow, a tumor in which we have cell division, irregularity of the vessel architecture, which leads to tumor hypoxia. And hypoxia is a topic that you will hear a lot talking about because it's a serious concern when we treat a patient, and one of the limitations that we have by using just a physical dose approach. Additionally, we have a varying cellular density and also different metabolism for those tumors, all in the same tumor. And this can only vary strongly throughout the volume of a single macroscopic tumor mass and cause different levels of radiation sensitivity inside the single tumor. So there's a lot going on in this tumor that covering with an homogeneous dose cannot actually take into account. So one strategy would be moving to biological adaptation. I mean, this is an educational lecture, and so I've put some references for you. This is very nice work from Daniela Torvalds' group, in which she talks about, dose painting. And the paper is talking about the biological adaptation, which is based on knowing the radioresistant mechanism of tumor, sort of imaging them by using some sort of functional imaging. For example, hypoxia can be imaged with PET hypoxia, looking at extracting some imaging parameters and then correlate those imaging parameters with outcomes. So, and also with the dose that we're going to do, sort of deliver to the patient. And only in this way we can achieve the biologically adapted radiation therapy. However, we are a little bit at this stage in a way, because before dose painting and so that biologically adapted radiation therapy can be delivered, we need to be able to meaningfully visualize those radiobiological targets. So what is the solution to our problem? Is to go back to the beginning of, radiation therapy and remember the 4 or 5R or radiobiology. Just because it's an education lecture, I will read them. We have reassortment and reoxygenation. Reoxygenation is hugely important for us, especially when we're treated with low lead type of radiation. And then we have repair and repopulation. Repair, again, very interesting, very, very useful, very important in fractionated treatment. And then repopulation, which becomes very important for those treatments like brachytherapy, where we have low dose rates in which, some of this repopulation can come into effect. And then obviously we have the overall arching radiosensitivity. So we need to take advantage not only of the normal tissue biology, but also of the tumor biology. And only if we do that, we can personalize our treatment indication, potentially creating those early synergies with those systemic therapies and immunotherapies. We know that for some tumor, radiation therapy is not enough alone. We need to combine it with other sort of therapies and pharmacological therapies, and we need to be able to design that radiation therapy treatment in a way that maximizes those systemic therapy. So what are the tools that we have in our toolbox? And this is where we physicists become very excited about it. The first one is obviously imaging. And this is becoming more prevalent because of the introduction of artificial intelligence. We have the ability to extract a huge amount of information from these images. And if you think about it, we do acquire a large amount of images for each of one of the patients. We have the diagnostic scan, we have scans that we acquire before radiotherapy in order to deliver and create a beautiful treatment plan that we're going to deliver to the patient. We also have a lot of imaging that we do during the treatment of the patient, which potentially can be useful to diagnose, some changes in the patient. And then, of course, we have the scans that we do after. And this can be MRI, that can be CT, cone beam CT based, or, for example, we can have a functional imaging like the hypoxia PET I was talking to you about. So we do have now the ability, because of fast processing and artificial intelligence, to extract a large number of quantitative imaging features. And obviously, I'm talking about, the field of radiomics and extracting those features that can be shape features, textures, or sub-regions, for example, that we can look at, that then we can correlate using some statistical analysis, which can be as simple as just a logistic sort of analysis, or we can use more complex like deep learning type of methodology. We can then correlate this information to some sort of outcome and then use that in a prognostic way to treat further patients and the patients that will come afterwards. So the radiomics has obviously been around for quite a while. I mean, here I've put some references for you. This is an important paper that was published by Professor Lambin. Professor Lambin from Mastro has done a lot of research in the field of radiomics and obviously believes that radiomics can be really useful for us, for our treatment in designing them. And then I've put also some references of radiomics use from specific cancers like head and neck and prostate, for example. There is also this world page here, radiomics.world, that you can sort of look at, and it will have a nice video in which they will explain some of the principle of radiomics. I thought I will bring some example of imaging biomarkers and how they can be useful for some treatments. One of the example is obviously the hypoxia imaging biomarkers. I mean, I've talked about hypoxia PET. However, imaging biomarkers for hypoxia can also be based on MRI. There are some papers here that you can look at in which the authors have looked at hypoxia imaging in the context of glioma. This is quite an active field of research, and here in which they've looked at hypoxia biomarker in the context of prostate cancer. So looking at these imaging biomarkers for hypoxia, as I said, they can be extracted from MRI and PET. They have these advantages, like, for example, in particular, MRI for most clinics, they can be available, they can be, they're regularly utilized. However, in assessing hypoxia, they still have some limitation for which we don't see them used as a clinical tool in order to prescribe and sort of design that treatment very often. In terms of MRIs, most studies use this blood oxygen level dependent bold type of sequence in combination with the dynamic contrast enhanced imaging. And these methods have been around for over a decade. However, if you look in the literature, there's still limited validation for these methods as hypoxic biomarkers. Then in terms of PET, I mean, I am very, very lucky. I'm in an institution where we have a few PET machines. However, not everyone can access PET as easily. However, PET, it's not only not accessible easily, even if you have it, does have some spatial and temporal limitations. Usually they're quite poor, and also they're very much impacted by the altered blood flow in the tracer uptake. So we have a long road ahead, and this is a very nice work again from the UK, from the group of Professor Catherine West, in which they've looked at all the steps that we should have to implement in order to introduce, for example, an hypoxia biomarker in our clinic. So it's a long road because we have to go through all of these steps. These are 6 steps, and I think it nicely summarizes all the efforts that we have to do in order to use this type of technologies. So we need to have a proof of concept in which we need to understand that imaging biomarker can actually look at the difference in expression with without the outcome. we need to do some analytical type of validity, and it needs to be robust, and it needs to be reproducible, and it needs to be reliable. Once we have done these first, let's say, preclinical sort of steps, we need to go into the clinical validity. So we need to make sure that these imaging biomarkers are prognostic in multiple independent cohorts. The best are, model prognostic factors that can be applied to different cohorts in different parts of the world. For example, they become much more, useful. And then we have to understand the incremental value of introducing an imaging biomarker. It might be very expensive to, for example, do some sort of imaging for a patient. And so it needs to really add a lot to that patient treatment. And also we need to look at the clinical impact and the utility. And as I said, the cost effectiveness, it's an important step in the overall picture. So in terms of translating these imaging biomarkers into the clinic, there is some nice work out there. One that I would like to bring up is this one from the group of Daniela Torvald, in which they have looked into dose escalation to hypoxic subvolumes in head and neck cancer. This was a randomized phase 2 study in which they used dynamic fMISO PET CT. And this was an interesting study that had the purpose to confirm the prognostic value of the hypoxia PET and also assess the feasibility, the toxicity, and the efficacy of this hypoxia dose escalation. So what they did is that they sort of divided the patient into patients with hypoxic tumors, which were either randomized into the standard radiation therapy arm, which is the usual 70 grain 35 fraction for head and neck, used quite widely around the world, or to dose escalation, in which they escalated the hypoxic area to 77 gray to 35 fraction to this, hypoxic volume. And then the patients with non-hypoxic tumors were treated with the standard of care. So this is a beautifully designed study that unfortunately was prematurely closed due to slow accrual. And one of the comments that is made in the paper is that the slow accrual was potentially due to the fact that it was quite hard to, acquire these PET images and process them. Unfortunately, these results are non-statistically significant, but showing good promise in terms of outcome after hypoxia dose escalation. So you see that there are still some limitations in translating these imaging biomarkers into the clinic. Additionally, there are other challenges that I wanted to bring up. And in order to bring up these challenges, I thought I'll bring up the very nice work from one of our colleagues, Dr. György Kotari here from Peter MacCallum Cancer Center. So her PhD was all on looking at radiomics as a gateway to understand lung cancer. And what she had as an hypothesis was that imaging feature will correlate to clinically significant oncology endpoints in patients with lung cancer. When she started her PhD a few years ago, she published this very nice systematic review and meta-analysis in which she looked at the prognostic values of radiomic-based models for these non-small cell lung cancers, which were treated with curative radiotherapy. And the work is really interesting because it highlights some of the limitations that we have been having so far in terms of imaging biomarker. So she highlighted that radiomic models alone have modest prognostic capabilities, that they have significant heterogeneity in the methodology, in the features that are selected, and also in the performance of these models. There is a huge amount of heterogeneity. And then also she highlighted the importance of employing a transparent, robust, and reproducible method for performing these radiomic studies. So it's not all bad news. There is a lot of very good work out there. This is a nice work that's just been published in February of 2026. In April 2026. And published very recently. And it is a nice roadmap that shows the role of diffusion-weighted MRI in biologically image-guided radiation therapy. So what it does, this paper, which is very nice and it's here for you to have a look at, is that it is a roadmap which provides a comprehensive framework for integrating this diffusion-weighted imaging into radiation therapy, with an emphasis on its application in MRI image-guided radiation therapy, and also the potential for driving biologically based image-guided adaptive radiation therapy. So have a look at it, because it's a very nice work with a lot of useful information. Additionally, we know that there is the Image Biomarker Standardization Initiative, which tries to, overcome some of the limitation of the studies that we've seen in the past. And this is an international collaboration. They like to say it's independent from the vendors, which works towards standardizing the extraction of these imaging biomarkers from acquired imaging for the purpose of high throughput quantitative image analysis, so for radiomics and such. So I've put that one there too, in order to sort of leave you with the idea that these tools are there and we should be, using them. We just need to do it properly. Okay, so let's go back to other tools that we have. One of my favorite tools is obviously radiobiological modeling. So I've brought back a paper from 2012, and I hope you have read it before. Is the task group the AAPM task group 166, which was a task group which was sort of focused on the use and QA of biologically related models for the use of treatment planning. So it is a very nice, important publication, which unfortunately is quite old. And as we know now, we're still using physical quantities, but it sort of said that, at the time, the quality of the radiation therapy plan was judged by physical quantities, which are surrogate measure of biological responses, but that instead treatment plans should be optimized using directly radiobiological criteria. So they were advocating for the use of tumor control probability and normal tissue complication probability in order for the treatment to reflect the clinical goals that the clinician wants to achieve. At the moment, what we use is a physical dose, which is associated to a certain outcome. Their idea was to use these parameters directly in our optimization and also in the creation of the plan. Obviously, we're not doing that in the clinic, or maybe some centers are, but there are centers that have, a lot of research capabilities. In the normal standard clinical practice, we're not using them, and there are reasons why we don't use them, and there are limitations of these models. The first limitation is that a lot of these NTCP and TCP model, and here I put in the Quantec, because obviously the Quantec is used quite extensively as a reference for our clinics, is the data collection. Data collection can be tricky, we know. It can take a lot of time, and also we need to be sure that the data that we're putting in our model is high quality data. Additionally, a lot of the traditional radiobiological models are sort of fitting doses which are extracted by dose volume histograms. So you see immediately the limitation there. The dose volume histogram is a 2D representation of 3D information, and it's done by using an empirical approach. And the parameters that we have in these models, there's a lot of always skepticism when one uses a model for a study. What parameters did you use? Are these parameters relevant for your clinic? This is a very important point. We have to make sure that if we parameterize a model in our clinic and then we send it to our friends across the road to use in their own clinic, we have to make sure that that really respect the patient cohort. So there are guidelines on how models should be and should be validated. They are the tripod statement guidelines. Have a look at that publication. They have recently published one on AI as well. And in this, obviously, they show you the power of having an external validation. So a robust NTCP or TCP model should be applicable to all and should be generalizable and transferable. And this is, again, another limitation. That's why we haven't used it yet. Another point that I wanted to make, and I hope it came out from what I said, is that a lot of these models, as I said, are based on dose volume histograms. Dose volume histograms have two inherent big assumptions. One is that all the doses flatten in 2D. And the second, more important one for me, is that they're based on the contouring that one has done in their CT scan. So it's sort of a priori knowledge in which we decided that contour, for example, is a certain organ at risk or a certain tumor. And the idea is to move on from this concept by moving from a 2D representation of the dose to a 3D representation of the dose. I mean, when we show a treatment plan to a clinician, when we create a treatment plan, we don't only look at the dose volume histograms, but we also look at the dose distribution. We go up and down with our slices. We look at the hotspot. And so obviously there's been a lot of work in the direction of using this 3D dose distribution also in models. And again, there's been some variation, but at least there's been some collaborative work in trying to make this more standardized. I've just bring here some nice work from Laura Cella's group, in which they have written a methodological cookbook in order to do voxel-based analysis, and then another international collaboration that was stemmed from one of the ESTRO workshop, in which we looked at a roadmap for clinical transition of these voxel-based analysis sort of models. Here you have some papers that show application of voxel-based analysis in the context of, for example, thoracic cancer, and also in the context of, particularly in the context of non-small cell lung cancer treated with photons and also with protons. So you can have a look at how such models and such sort of way of using the dose in a 3D sort of fashion can be useful. Another example that I like to bring up is a notable example, which is a nice study done by the group in Manchester, in which they looked at the results of the RTOG 0617 sort of clinical trial, and they've reanalyzed in the context of voxel-based analysis. For those who don't remember, the RTOG 0617 trial presented the worst survival for patients with lung cancer that were treated in the high-dose arm. And in the multivariable models, the radiation level and the whole heart volumetric dose parameters were associated with survival. So in this study, which is very interesting, 458 patients were reanalyzed with voxel-based analysis. And you have to think that in a way, voxel-based analysis is unknown. So you don't really need an anatomical region in the base of the survival. Of tumor volume, midline dose, and heart region dose, and at this point, they didn't find any significant difference in survival between radiation level. So obviously, if you are starting looking at doses in a 3D way, you might find new avenues. One of these avenues is to look at, for example, different ways of planning your patients. So again, this study from Manchester has brought sort of new input in their clinical practice. So what they've decided to do is to look at dosimetric impact of sparing the base of the heart on organ at risk doses during lung radiotherapy. And they've done it in what they call the Rapid RT study. So the Rapid RT study is not a clinical trial, but it's a study in which they've studied sparing the base of the heart. So they have a sparing structure and a sparing objective on this structure in their optimization. And they're comparing the results of these patients in the next few years with the results of the patient that they historically had. And this is a nice way that we can also think about doing studies when we don't have the possibility to do a clinical trial, or maybe a clinical trial will never exist because of many reasons. Okay, so we've talked about imaging, we've talked about modeling and radiobiological modeling. Now we need to keep in mind that we can do a lot of beautiful correlation between, for example, dose and a certain outcome. But we have to remember that correlation is not always causation. And so we need to also look if the correlation has some clinical, sort of meaning. So another tool that I wanted to bring up, which I find very interesting, is the use of expert knowledge. So the use of causal inference, for example. So you can look at some correlation by creating what we call the causal inference maps, which are here. and they look a little bit like this, in which we include expert knowledge from different groups, in which we look into understanding the major influences among all the different variables that might be correlated into some, for example, type of outcome. This is nice work, which was published by Eliana Vasquez Osorio, and she looked at the dose-effect relationship for the inferior section of the brainstem and the dysphagia, which was identified with voxel-based analysis. And then it was also studied additionally with causal inference method. So there is a fear sometimes that causal inference could potentially influence or bias your result. And so they did 2 causal inference map, one in the UK, one in the United States, and they looked at the results and they found that they're very, very similar. So they found that it made sense that there was a correlation between the inferior section of the brainstem and dysphagia, because that's where the swallowing center are in the medulla oblongata. So there is a lot of importance in keeping in mind that we always have to think about the clinical reason for some correlation and not take them just as, for granted. Okay, another tool that I would like to bring up, because this comes often in combination, for example, with imaging biomarker, is the use of genomic factors, so some sort of genomic biomarkers. This is a study, and I have to thank Dr. Tiziana Rancati from Milan for giving me some of the slides, or some of the pictures that you see in my slide, in which they've looked at, for example, incorporating genetic information, doing modeling. So this is part of the prospective multicenter observational required study, which was run between 2014 and 2018. In this required study, what they did is that they look at validation of predictive models and biomarker for radiation therapy side effects, in order obviously to reduce them and also improve the quality of life in cancer survival. And they've done this by collecting a huge amount of information. So they've collected about 4,400 breast, prostate, and lung patient data. They've collected all the clinical dosimetric toxicity data, patient-reported outcomes, and also DNA. By collecting the DNA, they have extracted the polygenic risk score, incorporating the SNP-CP interactions, and they've looked at the model also by stratifying patients according to this type of polygenic risk score. This is some of the results. The continuous line represents the results at 5 years. The dotted line represents the results at 3 years. And they have stratified the patients in resistant patients, the red lines, in black you have the normal phenotype, and then in green you have the radio-sensitive patients. And you can see that this probability of toxicity changes quite dramatically. I think if we look at grade 2+ late urinary toxicity, and we stratify the patients according to their phenotypes. So it's an interesting sort of aspect that we can include in our analysis, and it could be very well combined, for example, with the imaging biomarkers. I am not an expert in this, but I thought I will bring it up. There is also work in looking at genome-based models for adjusting radiation dose, and this has the acronym of GUARD, and there are quite a few publications out there that look at these applications. So it is what I was talking about, so using gene expression and using it to sort of drive the radiation therapy in a way, and to derive the genomic adjusted radiation dose. So in this paper, the authors looked at predicted clinical outcome in breast, in lung, in glioblastoma, and pancreatic cancer. And then in the breast cancer cohort group, what they show is that the 5-year distant metastasis-free survival was larger in patients with high GARD values than in those with low GARD values. So there's a lot of potential in doing studies like this and having some biomarkers that we can then use to design our treatment. Okay, so I think it's important that we remember that all of these studies that I've talked about before use, in a way, patient data. And it might be that we don't have enough patient data in order to study all the complexities of our, system, which is in our case for radiation therapy, physical system is our patient or is the tumor itself. But we might need something extra in order to do all of these different sort of permutation and look at what effects we might have. So there is a very emerging field in radiation oncology. I say in radiation oncology because this field has been used many, many years in other professions, for example, which is the emerging field of the use of digital twins. So what's a digital twin? So a digital twin, it's a computational model or group of models that evolves over time. So it's different from a static model in a way. And this evolves over time to persistently represent the structure, the behavior, the context of a unique physical asset, such as a component, a system, or a process. So this is the engineering sort of definition of a digital twin. A simpler definition is this virtual representation of a physical system. And for us, the physical system, as I told you before, is the patient. What it does is that it mimics structure, context, and behavior of the system. For us, the structure is the tumor, the tissue, or even the cell. So you see how small and granular we can go with the digital twin, while the context is the patient scale, environmental factors, and the behavior is the models that we're looking at. So, and again, I need to acknowledge Dr. Luca Possenti from Milan, from the Polytechnical School, for providing this slide, and also for, in a way, being part of this nice work that I will talk to you about. So there are publications on digital twins. This is a nice publication that is a survey and looks at some applications, so more general for you to have a look at. And this is instead work from the group in Milan, Tiziana Rancatti's group in Milan, and the Camon Lab, in which they're looking at, digital twin application in order to mimic patient-specific microvascular for estimating radiotherapy outcomes. And I think this is very fascinating because it does present a personalized computational framework for modeling this vascular microenvironment and evaluating the impact of microvasculature on radiotherapy outcome. There's a lot of research that shows that microvasculature is very important in correlation with the radiotherapy outcome. So a digital twin like this can give us, the platform to study that without having to collect an enormous amount of patient data. It does take data, though, to create the digital twin, so the work is still there to be done. Another important factor that we have to remember, and here the biology is very important as well, is that radiation therapy alone is not enough, as I told you at the start, in order to treat some of the tumors that we treat with it, but that we have to use combined approaches. And in terms of looking at combined approaches, one that comes to mind is obviously immunotherapy. And it is important that we understand the immune response, and in order to make that synergy as efficient as possible. It is important that we understand the impact of radiation therapy on lymphocyte counts and other blood metrics. And there is a very active field of research. This is very nice work, again, from Laura Cella and Giuseppe Palma, where they have done a critical review of all the frameworks that look at this radiation-induced lymphopenia topic. And in this review, you will see that they have identified some frameworks. One is using blood irradiation model, and one that you might want to look at is the HEDOS model. There is also a flip HEDOS model. These are models that simulate the dynamic nature of the blood and allow you to actually have a time-dependent organ or blood DVH here. There are frameworks that are based on advanced machine learning, which can incorporate patient-specific clinical and dosimetric factor. Obviously, we have the power of machine learning and deep learning and all the sub species of machine learning that we can use to do some of this analysis. And then some of the frameworks that have used voxel-based analysis in order to identify areas which are responsible for toxicity and radiation-induced lymphopenia. So have a read of this paper if you're interested in the topic, and there are a lot of good references there that you can look at. Finally, I just wanted to bring our experience in this because our group at PTMAC has also been looking actively into dose-response relationship between radiation exposure and bone marrow function. looking at, PET, for example, images, but we've also looking at dose response relationship. And the final aim of this is to come up with some planning strategies in order to reduce the effect of dose into these immune organs, but also into these areas which might sort of be more affected by radiation-induced lymphopenia. This is our work, which has shown that, we know very well that radiation-induced lymphopenia is a negative prognostic factor for patients in terms of survival. And this is work in which we have shown in our cohort of patients how monocytes, neutrophil, and lymphocytes change during radiation therapy and after radiation therapy in non-small cell lung cancer. And obviously, these immune cell subsets are key prognostic factors. This has been well established. But what we need to now know and sort of find a way to transfer that into the clinical practice, because they can offer potential biomarkers for identifying high-risk patients and also guiding some therapeutic strategies. And I would like to thank some of the colleagues here at Peter Mac for all the work done in this space. This is not a tool, obviously, so I didn't put tool here, but a very important point that we always have to keep in mind when we work in our field in radiation oncology is the patient. We never have to forget that there is a patient at the other end and that we're treating that patient. And it's important to remember that the way a patient perceives morbidity might be different from one another. And this is still related to their biology, their radiosensitivity, both of the tumor, but also of the organs at risk, in particular, if we're looking at morbidity. So, and as I said, this is even for the same tumor or similar dose volume parameters for the normal tissue. So even if we are delivering the same type of treatment and we are within those constraints that we have decided are safe, we have very different responses from one patient to the other. So what is really becoming important, especially with the introduction of a lot of electronic, tools in our clinics, is the role of patient-reported outcomes. This is becoming way more important, in particular because now we have some validated patient-reported outcomes tools, which can enable us to identify patients requiring specific attention. And these can correlate in some cases, and there is research in this field, in a generalizable manner to objective scores. And in a way, having these tools could be another way to personalize our treatment and make it more precise for that specific patient. So just to show you some examples, this is work from the group in Groningen, in which they have prospectively collected real-world data that included the patient's perspective. And they have used that in order to personalize treatment. So they have studied 30 head and neck cancer patients, and they've looked at the feasibility of semi-automatic quality of life, weighted, NTCP-guided VBAT treatment plan optimization. So it's a mouthful, but it has all the components. It has plan optimization, which is the usual plan optimization with physical parameters. It has the introduction of quality of life and also some normal tissue complication probability models. So in this study, the treatment plans were optimized partly automatically and partly interactively. So automatically with the quality of life weighted NTCP-based optimization functions, and also interactively by moving and changing those conventional dose-based optimization functions that we use every day. And also they also did an analysis by looking at a quality of life score at the end of treatment. So this is a very interesting study that you might want to have a look at. Finally, this is all bringing us to personalization of radiation therapy. So can we move towards precision radiotherapy that is also robust? Because so far I've given you all of these different tools, but then we need to decide where to use them, how to use them, and to use them in a robust and safe way for the patient. So I think we can. And in this context, I would like to bring up the idea of probabilistic planning. So probabilistic planning in which we move from a definition of gross tumor volume, which is the gross tumor volume contoured by the clinician, in which the clinician already puts a lot of that sort of information that they have on the patient. But now we introduce a gross tumor map which is a probability distribution of the most probable presence of the tumor. And we can move towards a CTV approach to a CTM approach, in which we have the probability distribution of clinical targets that contain the disease to be irradiated. And finally, we can we can move from an organs at risk to an organ a risk map, in which we have the probability distribution of clinical organs that, if irradiated, could suffer morbidity. How can we move from this definition to a map definition? By using the different tools that we talked about. So we can do a cartography in which we map the disease and the critical structure based on patient-specific imaging data and all the other knowledge that we have, patterns of failure, for example. And we can also include in this probabilistic planning some uncertainties that we certainly don't have in our treatment, except, I have to say, in proton treatment, they still have some uncertainties. So can we personalize radiation therapy? We certainly can, and we certainly should. And this is a publication from a few years ago, which I like to close my talk with, which is talking about tumor heterogeneity research. It's from the NCI Radiation Research Program portfolio. And this was looking really at innovation in biologically based radiation therapy. And the beginning of this paper is very enlightening, because it says that we are at that point in which the field of radiation biology and the clinical application of the radiation oncology are undergoing a conceptual change, as the definition of treatment dose expands from a purely physical quantity of energy deposition to include also the biological impact. You have here, it was published in JCO. It's a few years old already, so I would like to see some of this implemented more, but there are very interesting studies out there in which the biological side is now addressed more, even in clinical trials. So with this, I would like to thank you very much for your attention, and I would like to thank a lot of my colleagues, in particular the Peter Mac Department of Radiation Oncology team, for the work that we do together every day. Thank you very much.
Thank you so much for your very insightful and informative lectures, and I think this is the best lecture that I heard this year.
Oh, well, thank you. I'm trying to, sorry, I will minimize this and try to see you all, because it's very hard when I cannot see people.
Yes, she delivered a lecture about biology-guided radiation therapy. I think she covered all of the topics regarding biology-guided RT for this at this time, I think. So we have some questions from the floor.
Now that I can see the question chat, I can hopefully see.
I think first one is about the recording or presentation material. I think, apparently, I think the AFOMP education committee members, I think we can provide recording or presentation, I guess. Jihun,
yeah, I don't know if it was recorded. Oh, yes, it was. Yes, that would be fine.
Can you provide people
I guess
record video or presentation?
Hamid is already recording everything, and we can send the link later.
Okay. Then one question from the floor is, what is the data size and key data set required for radiomics quantitative analysis, and what are...
That's a very good question, isn't it? I guess it was something that you have to develop with your statisticians and see what sample size you need for the outcome that you're looking at, or for the prognostic sort of value that you want to look at. I think it's hard to say you need this amount of data or that amount of data, but definitely for radiomics studies you shouldn't have 10 patients. You need quite a large data set, but it needs to be a curated data set. So the more curated is your data set, the less data you might need. And the more noisy is your data set, the more data you might need. So I think it's a very broad question that needs to be addressed depending on what you're studying and what you want to achieve from that.
Yes.
And if anyone in the crowd is expert of radiomics data and knows how many data you need. They can also put maybe in their experience, but I know that, you know, the few studies I've been involved, it's more than 100 patients usually. And radiotherapy is always one of those fields where when we show the statistician our numbers, they're like, oh, this is too little, because they're used to epidemiological studies or studies where they have thousands of patients, while we need to, you know, be realistic, and the patients that we have is what we can study. So that's why, in a way, if we want to develop a lot of interesting radiomics prognostic factors, it would be nice if we could collaborate more across institutions.
Yeah, I think we can, maybe I can tweak a question just a little bit. I mean, if there is any magic number for the number of data sets for radiomics, I guess.
Yeah,
I mean,
no, I
oh,
wouldn't say no.
maybe I think that there are many students in the floor. Maybe they start
Yeah.
the radiomics related study. I think they are really wondering, how many data sets they should collect.
Yeah, I think they should look at similar studies in the literature to see what size
Yeah.
and what results the other, because this field has been going on for, you know, more than 10 years, and yet we are not using radiomics every day. So in my opinion, just start from, like, as a suggestion, I would say start from looking at other people's work and see what you can add to it.
Yeah, I think we need to have a sufficient number of data sets for radiomics analysis, because we need to develop machine learning model that we can use the features that are extracted from radiomics. Then maybe
Yeah.
I think the smallest number of data sets would be like 30 or 50 for machine learning model. I think that's the smallest number that have seen for the radiomics analysis. Then if we have very precise model, then maybe we should have more than 100, or in some studies maybe we can see over 1,000 of data sets maybe needed.
Yeah. I mean, we have to remember that, especially with classic radiomics like pi radiomics, will extract, more than 96 to 106 features and something. So it's obviously something that you have to keep in mind when you're starting your work, that you're going to, if you extract more features than patients that you have, like, it's, in a way, you have to make sure you have enough data so that those features are significant.
Yeah, I think conventionally for radiomics, I think a CT imaging or MR imaging has been popularly used, I think.
Yeah, there's also studies with PET. Yeah,
PET
as well. Yeah.
Okay.
Yeah, this group in Switzerland has worked a lot on PET, and they actually have a very nice PET repository. So yes, if you're interested in PET as well, there is that side. But it all comes down, it's hard to compare your work with somebody else's work if the way they've done the analysis is not clarified, how they normalize the data set, how they have, done all the cleaning up, the masking and all of that. So that's why, if you're starting a work like this, just look at sort of standardizing the way you're going to be doing it. Yeah, and also the images that you are using for these studies.
Yeah. Any questions from the floor? And I had the two questions, but I think Professor Panettieri already covered my questions during her lecture, I think. And
Okay,
one question was about any research, your research regarding the biology guided RT, but you showed already an example. Then
yes.
Another question was about the radiobiological model example that was used for the clinical inverse planning, because inverse planning has been conventionally based on dose volume histogram. And I think, I was wondering if there is a commercial software or any research efforts in which
Yes.
the radiological biological modeling has been utilized.
Yes, there was, and there is, like the race and I'm not representing any vendor, but RaySearch and RayStation has modules for research that include biological optimization and biological parameters. Eclipse for a while had a module many years ago, but they don't anymore. And I know that Monaco also had some biological. Pinnacle used to have a research version where some studies have been done by using biological sort of parameters in a way. There is a trial that was run in the UK years ago called BioProp, in which they used Research Pinnacle to create a plan that was based on TCP and NTCP, and then they would transfer the plan into the normal Pinnacle to treat the patients, because obviously we can't treat with the research system. So there are some efforts, I would say, probably without representing them in any way, but RaySearch would be one of interest to look at. And even the work from Groningen, I think, was done, if my memory serves me right, it was done with RaySearch, with the research version of RayStation.
Yeah. Thank you very much. So it's already 5 o'clock, and I think probably some people may have some questions, but I think we need to close our session. And thank you very much again for your insightful lecture.
No, thank you. Thank you for chairing and moderating, and thank you, Dr. Chen, for making us also here using all the system.
Okay, thanks a lot.
Thank you. Thank you, everyone.
Let's close this section, and thanks to Vanessa, and thanks to Kim for host this.
Thank you very much, everyone.
Bye.
Bye.
Thank you.
Bye.